I'm Janak Goyal. I'm a rheumatologist in private practice. I am associated with Raritan Bay Medical Center, Perth Amboy, New Jersey, and Robert Wood Johnson University Medical School in New Brunswick. I am practicing rheumatologist and have an interest in musculoskeletal ultrasound. Have been doing ultrasound of the musculoskeletal areas for about 7 years. Okay, what I'm going to talk about today, I'm going to talk about some of the techniques which I use to guide injections under ultrasound guide. These are some of my disclosures. I'm a consultant for Sonosite and also work as an instructor for Abbott. These are some of the key references pertaining to my talk. Now, these are some of the techniques of ultrasound guided injections. There are many different techniques which can be used for joint and soft tissue injections, but the technique selection depends upon the equipment, location of the target lesions, and also on the experience of the physician who is performing the technique. But for a safe and accurate injection, you need to have a sound knowledge of gross anatomy and surface anatomy, and also the knowledge of ultrasound beam. This is what the ultrasound beam looks like, and this is how your image will look like. You have ultrasound beam which is three-dimensional, has lateral, axial, and elevational dimensions, whereas you will only see lateral and axial dimensions on your image. Now, these are some of the commonly used ultrasound guided needle insertion techniques. There are two main techniques. One is called the direct method and other is called an indirect method. Again, under the direct method, you could use two techniques. One is called in plane and the other is out of plane. And in an indirect method, you could use a technique by marking the borders of your target lesions, or you could use a paper clip to really direct to mark the point of entry for your needle. Here in this video clip, you are seeing a needle being inserted, an in-plane approach, and you see the needle as an echogenic band. So here is the in-plane needle insertion technique. Here you see the relationship of my needle to the transducer face, and here you are seeing the needle being directed under the transducer in a direct in-plane technique. This is what you will see in your two-dimensional image, a needle seen as an echogenic band, and this is the relationship of your needle to your ultrasound beam. The needle is right in the center of your ultrasound beam. Here is a video clip which is demonstrating the direct technique for needle insertion under ultrasound guide. Here is a needle going directly into the radiocarpal joint and seen as an echogenic band. So this happens to be the wrist joint being injected under direct ultrasound technique. Here is the out of plane needle insertion technique, some of the details. This is the relationship of your needle to the transducer face, and here is needle being inserted out of plane, and this is what you see on your screen, an echogenic dot, and this is the relationship of your needle to the sound beam. Here is a video clip. This happens to be the knee joint. Here is the needle shown as an echogenic dot and filling the suprapatellar recess of the knee joint. Now, relationship of needle to the structure. So, needle versus structure orientation. You could have two kinds of orientation. One is a long axis to the structure. Here is the long axis to the structure. Here is the short axis of the structure related to the needle. Now, needle versus sound beam angle, very important for the visualization of the needle. If the needle is parallel to the transducer face, it will be seen better, but if it is perpendicular to the sound beam, you will not see it. So, as the angle increases, the visualization of the needle will decrease. So you will try to keep the needle as parallel to the transducer face as possible to properly see the needle. So what is the problem with this picture? You don't see the needle. Why don't you see the needle? The reason is needle is going almost parallel, almost perpendicular to the transducer face, and the sound beam will not be hitting to this needle, and you will not have any reflection from the needle, and you will not see the needle. What do? You adjust needle to the sound beam angle. So increase the angle of the needle or use a different approach. What is a different approach you could use? You could use a software which is helping to see the needle. Here you see there is a needle which is going into the glenohumeral joint, and you barely see the needle, but you could see it clearly getting into the glenohumeral joint. On the other side, here you see a software which helps to make needle more visible. So you are seeing the same needle getting into the glenohumeral joint and clearly far better visible than the needle you have without this software. Here is another problem with seeing the needle. You are saying I cannot see the needle, but if your transducer is tilted away from your needle, then you will not be able to see the needle because sound beam is not hitting your needle. So in this situation, what you will have to do, either you will have to adjust your needle angle to the transducer, or you use a needle guide. In nutshell, the tips for needle insertion: you must anchor your transducer to avoid sliding. You must make sure that your transducer is very steady. Learn to scan with a non-dominant hand. Penetrate skin and insert the needle for about 1 centimeter before you advance it. Find the needle and pay careful attention to the needle tip. Please do not advance the needle if you do not see the needle tip. And never try to move both needle and transducer together. You will never find the needle. So let's not get ready to do some procedures, and I will show you some of the common procedures which I perform under ultrasound guide. I will not be showing you anatomical details, but I will try to show you the interest area of injection in some of the anatomical areas. But before I begin, you must perform a full sonographic examination to identify and define your target and choose shortest and the safest route. Mark the site of needle insertion with a blunt object like the tip of a ballpoint pen. Select a proper transducer and needle, and do not forget to maintain aseptic precautions. Here is a carpal tunnel injection. This is the ultrasound view of the carpal tunnel. Here you see this is the FCR tendon. What I usually do, I will go over the FCR tendon and direct my needle in a space between the median nerve and the flexor pollicis longus tendon and deposit the medication between those two areas. Here is the picture how I perform this. Here is the wrist joint injection. You see the patient positioning here, and here you see the radius, lunate and capitate. Here is the needle which is being directed into the radiocarpal joint under a direct method. Here is my radiocarpal joint, and here is the needle performing the injection. The tendon sheath injection of a flexor tendon. This is the patient positioning. Here is the needle going parallel to the tendon right under the A1 pulley. So once I reach under the A1 pulley, I inject, and you clearly see the spread of the entire material around the tendon. The first CMC joint injection, I use the longitudinal in-plane approach. You could go from proximal to distal. Here is your metacarpal, here is the carpal bones. I am going from proximal direction to distal direction into the first CMC joint. On the other hand, you could use a different approach. You could go over your first metacarpal from distal to proximal. Here I am approaching this joint from distal to proximal, and here is a needle into the first CMC joint, and my injection into the joint. Again, MCP joint injection, similarly, there are two approaches, proximal to distal and distal to proximal. Here is the approach from distal to proximal. Here is your metacarpal and here is your phalanx. And on the other hand, this is an approach from proximal to distal. Here is the phalanx, here is your metacarpal. Now, DeQuervain tenosynovitis. You must scan before, must make sure that you define your DeQuervains, because sometimes there could be a septum dividing these two tendons, and the pathology may be involving only a one tendon. So you must direct your injection into that. This is the technique. I go right under the extensor retinaculum, right on the tendon. Here is my needle right under the extensor retinaculum, and here is the needle carefully injecting right over the top of the tendon. The elbow joint injection. So there are two approaches. You could have elbow joint, you could approach it from posterior or you could approach from anterior. And here is the approach from the posterior angle. Usually from the posterior angle, I would inject from lateral side, not from the medial. The reason behind, because the ulnar nerve is coursing right on the medial side of the triceps. And here is the injection getting into the olecranon recess. This is the needle proceeding into the olecranon recess. Once I reach there and carefully deposit my medication into that olecranon recess. This is the anterior approach. I am approaching this anterior recess. Here happens to be your humerus, radial head, anterior recess. Here is the radial fossa, and here is my needle anteriorly getting into that humeroradial joint and injecting the medication. Tennis elbow injections. So what I usually do, this is the position I put the patient in and define my common extensor tendon insertion. I go at the insertion of the common extensor tendon. Here is the needle getting into the common extensor tendon, and I will inject right at the origin of the common extensor tendon. AC joint injection. I proceed from lateral to medial, in plane approach. Here is the needle going from lateral to medial with an in plane approach and injecting. Biceps tendon sheath injection. So biceps tendon sheath injection, you could go from proximal to distal or distal to proximal. Here is from distal to proximal. Here is your biceps tendon. Here was your needle getting into the pathological area in the tendon sheath and injecting the medication. The shoulder joint injection. Usually I take the posterior approach for the shoulder joint injection. The needle is inserted through the myotendinous junction into the glenohumeral joint. Here is the needle getting into the glenohumeral joint, and this is my patient position. Subdeltoid subacromial bursa injection. Here is my subdeltoid subacromial bursa. Here is the peribursal echogenic fat which defines my subacromial subdeltoid bursa, and here is the acromion and here is your deltoid. What I do is I go from lateral to medially, carefully entering the subdeltoid bursa and injecting and watching the whole material getting and spreading the subdeltoid bursa. Let's look at the lower extremity, the hip joint injection. So hip joint injection could be very challenging and very rewarding. And this is a anatomical image of the hip joint. You see this is your anterior superior iliac spine, pubic crest, and inguinal ligament. The hip joint usually is almost in the middle of the inguinal ligament, about 2 centimeters below the inguinal ligament. So I will place my transducer on the femoral neck, almost in the middle of the inguinal ligament, and then go from distal to proximal and inject into the anterior recess of the hip joint capsule, as in this video. Here is the lliopsoas bursa injection, could be very rewarding also. This was the lliopsoas bursa, which was distended in a patient with rheumatoid arthritis. So I have taken an approach from lateral to medial, and the transducer is placed in the transverse location of the hip joint, and the needle is inserted in a in-plane approach. Trochanteric bursa injection. This is my trochanteric bursa. I see this gluteus medius tendon insertion and the bursa underneath. So I take my approach from distal to proximal or proximal to distal. In this situation, I am going from proximal to distal and proximal to distal. Here is the muscle, here is the tendon. The knee joint injection, there are so many approaches for knee joint injections that everybody uses a different approach. So some of the approaches which I have used, I usually use a suprapatellar approach. Usually a longitudinal out of plane approach is my favorite, and a transverse in plane approach. And you could use approaches, go through the retinaculum and medial collateral ligament, and some people do use infrapatellar approach, which I have never used. Here is a longitudinal approach. You see this positioning of the transducer, but the needle is out of plane. You're seeing that needle just as a dot, but here is the suprapatellar recess. You see the suprapatellar recess being filled with the material clearly. This is a transverse approach, again in plane. So I'm trying to aspirate the fluid from this suprapatellar recess. But if there is no fluid, I usually use the out of plane approach. Here is the approach through the MCL. Here is the medial collateral ligament. Here is the medial meniscus. So I go right under the medial meniscus at the attachment, right under the medial collateral ligament at the attachment of the MCL to the capsule and inject. So you clearly will see the material. Here is the needle, and you will clearly see at the junction the medication being deposited in the knee joint. Here is the medication. Here is an approach from the retinaculum. It's basically the approach which we usually use for the blind injection, but I use my transducer to look at the position of my needle, and here is the needle getting into the knee joint for my proper injection. Anserine bursa injection. First I define my Anserine bursa and go on the longitudinal plane of the Anserine bursa and direct my needle in plane into the bursa for injection. Here's the needle, in plane approach into the bursa. Baker cyst. The Baker cyst is very easy to do. People are sometimes concerned about the vessels, but once the Baker cyst is full, it becomes very superficial, just under the skin. Here is skin, here is the Baker cyst. Here is the needle into the Baker cyst. I'm aspirating the entire Baker cyst under ultrasound guide. Blindly, I sometimes may not be able to see where exactly it is. Here, the Baker cyst is completely emptied. Here is the ankle joint aspiration and injection. Somebody had a fluid in the ankle joint. This is my patient positioning, and this is the needle which is being directed under direct approach in plane into the ankle joint fluid. Retrocalcaneal bursa injection. You could use both in plane or out of plane. Here is the retrocalcaneal bursa being injected with out of plane. Here is the transducer. Here is the needle getting out of plane, shown as a small dot, and injecting clearly into the retrocalcaneal bursa. The first MTP joint injection, very common in my practice. I see a lot of people with gout. So I could go from proximal to distal, distal to proximal. Here is an injection from distal to proximal, getting into the recess of the joint and depositing the medication right into the joint recess. And make a note that in the small joints, you will see the capsule which expands and is distended proximally. So you do not need to put the needle in between the bones. Once you are in the capsule, you are at the right spot for the injection.